To Dr. Divya Kishan, Assistant Professor, GMC Kollam, for her talk.
So, a very good morning. A very good morning, one and all. First of all, let me thank Dr. Naveen for giving me this opportunity to speak on the topic Double Trouble by Binocular Vision Anomalies. So, we see that there is a drastic increase in non-strabismic binocular vision anomalies these days, and the prevalence in a study by Dr. Rizwana et al. Has been shown to be about in 30.8%, with convergence insufficiency being 16% and accommodative infacility being 10.8%. So let us see the case of this 9-year-old child who complains of double vision when reading. So on examination, you find that the visual acuity is 6.6 in both eyes. The anterior and posterior segment examination with special emphasis on ocular motility is within normal limits, and the cycloplegic refraction is also within normal limits. On detailed evaluation, you find that in prism cover test, there is a 12 prism diopters, exo for near and ortho for distance. The near point of convergence is 15 centimeter and near point of accommodation is OD and OS 8 centimeters. So we come to the provisional diagnosis of convergence insufficiency. And convergence insufficiency usually presents with complaints of blurred vision, double vision, eye strain, and headache, which is due to the sustained effort to increase the fusional convergence during the near task and difficulty in concentrating. But the word of caution is that in all cases that present with double vision, do not jump into the diagnosis of convergence insufficiency. That is because for patients it is actually difficult to differentiate whether they are seeing it as blur or double. And moreover, an underlying accommodative problem can present as a secondary convergence issue. So it is mandatory that in any child in whom you suspect a binocular vision anomaly, a comprehensive assessment of the orthoptics is mandatory, which includes the analysis of accommodation, vergence, and also the oculomotor function. So what are the convergence anomalies that we see? Based on the distance and near difference in the deviation, we can classify them into convergence insufficiency, divergence excess, basic exo, convergence excess, divergence insufficiency, basic ESO, and fusional vergence dysfunction. Accommodative dysfunctions that we see in common are accommodative insufficiency, ill-sustained accommodation, accommodative infacility, and also accommodative excess. So in these cases, a comprehensive evaluation, including that of accommodation, will include the near point of accommodation assessment, accommodative response by using the MEM retinoscopy, the relative accommodation, that is the NRA-PRA assessment, and accommodative facility assessment. The vergence ones include the near point of convergence, foria measurement, step vergence, and vergence facility assessment. So what are the tests that we do for convergence? The first would be to assess the foria for distance and near. Then we check the age-old near point of convergence, which we are all very familiar with. You can either use it with an accommodative target like an RAF rule, which is more common, but now we prefer more a pen light with red-green filter. That is because, especially in cases of children in whom the accommodation is very high, they will use the accommodation to overcome the convergence insufficiency, and so we may not get the real value when you look with an accommodative target. That should be done in a dim illumination, and you have to repeat it twice or thrice and take the average of these values. The third one would be a step vergence testing, where a positive fusion and negative fusion are assessed. In positive fusion, a prism bar with a base out prisms are placed in front of the eyes, and then the patient is asked to report the first blur and break in the values. Likewise, for negative fusion, the base in prisms are placed, and then the first break and break values is taken. Vergence facility is done by using the vergence flippers, which is 12 prism base out and 3 prism base in. Also, in all cases, it is mandatory to check the accommodative convergence by accommodation ratio, either by using the gradient or the heterophoria method. These are the normative data that we expect in patients with during the convergence assessment. NPC should be about 6 to 8 centimeters. And foria up to 4 exo at near is normal and 2 exo at distance. The vergence base out 2316 and with base in 12.7, and vergence facility that should be 15 cycles per minute. Now, what are the tests for the accommodation that we do? That would include the near point of accommodation and accommodative amplitude assessment. The near point of accommodation can also be checked by using the RAF rule, and the accommodative amplitude is assessed as age-based, and the Holstester's formula was the one that we used earlier, but for Indian children, Dr. Rizwana et al. Has now formulated a formula 16 minus 0.3 into age, and by calculating, putting in the age in that, you can get the what is a normal accommodative amplitude for the age of the child. Now, accommodative response is done by using the MEM retinoscopy technique, whereby you are neutralizing the reflex at near by using the retinoscope when the patient is reading on an accommodative target. Relative accommodative assessment would be done by serially adding plus lenses in 0.25 sphere add-on, and then you see the first blur. You can check for the positive and negative relative accommodation values. Accommodative facility is done by using the accommodative flippers. We usually use the plus and minus 2 diopters accommodative flippers. And these are the normative data that you require for accommodation assessment. NPA is, as we said, it is age dependent, and you calculate it based on the formulas. The MEM retinoscopy or the accommodative response would be 0.25 to 0.75. Accommodative facility is 11 cycles per minute, and relative accommodation NRA is plus 1.75 to plus 2.5, and PRA minus 1.5 to minus 2.5. So we can group these data or values that we have got into positive fusional vergence data, which includes the positive fusional vergence facility, NRA, binocular accommodative facility, NPC, and MEM retinoscopy. And you find that in exophoria, the positive fusional vergence group of data will be lower than expected, and MEM and fuse cross-cylinder will show over-accommodation. And the negative fusional vergence group of data, the NFV, the negative fusional vergence facility, the positive relative accommodation, NPC and MEM retinoscopy data together form the negative fusional vergence. And patients with esophoria and asynopia, the negative fusional vergence group data findings are lower than expected, with fuse, cross-cylinder, and MEM showing under accommodation. So for this child, we had exophoria. You need to analyze the positive fusional group data. If it is low, calculate the accommodative convergence by accommodation ratio and compare the near and distance phoria. Distance greater than near, it would be a case of divergent sexes. Distance equal to near is basic exophoria, and distance less than near would be our case. In esophoria, you find that you analyze a negative fusional vergence group of data, and if it is low, you calculate the AC by A ratio and compare the distance and near phoria. Distance greater than near would be divergence insufficiency. Distance equal to near would be basic esophoria, and distance less than near would be convergence excess. If you find that the child has no significant phoria, then you have to suspect anomalies of accommodation. And you do the test that approbe the ability to stimulate the accommodation. If they are low, it is accommodative insufficiency. That test probing the ability to relax the accommodation are low, it is accommodative excess. And test probing the ability to stimulate and relax accommodation, it is accommodative infacility. And in some cases, you find there are no phorias or no accommodative problems, then you need to suspect cases of fusional vergence dysfunction. So now, once you have come to the diagnosis of convergence insufficiency or the particular binocular vision abnormality, the first thing that we need to do is to rule out underlying organic causes, because some organic causes can very well present with this binocular vision, they can simulate binocular vision abnormalities. For example, vergence dysfunctions can be seen in close-held trauma, psychogenic causes, Graves, multiple sclerosis, anemia and measles in children, and other neuroophthalmic causes, and that needs to be mandatorily ruled out before we start on a treatment of binocular vision abnormality. Accommodative insufficiency also, we have a battery of causes, and all these need to be ruled out before you diagnose it. Now, so what is the treatment modalities that we have? Based on the conditions that we said, we can either have vision therapy, or you can use prisms, or you can have added lenses. The phases of vision therapy would be: in phase 1 is to normalize the accommodation amplitudes, develop voluntary convergence, and normalize the positive fusional vergence. In phase 2, it is the ability to stimulate and relax accommodation and train the vergence facility. And phase 3, integrate accommodative facility to oculomotor training. So we have a lot of vision therapy instruments which can be used for these. The simple ones that we know for the convergence would be our pen push-ups, you have the dot cards, cat cards, and Brock string exercises can be used so as to simulate the convergence. The accommodative disorders would be benefited by using the heart chart, where you can ask the patient to read a near target and a far target. Thereby you are sequentially stimulating accommodation and relaxing the accommodation. You can use accommodative flippers, plus and minus lenses, and when the patient uses this also, there is stimulation and relaxation of the accommodation. There are special instruments like the red rock, accommodative hoping cards, and loose lens rocks that can be used in cases of accommodative problems. Plus lenses can also be used in cases with accommodative insufficiency, and that should be titrated based on the NRA and PRA values of the patient. So thank you so much for the patient listening. Binocular vision anomalies need to be ruled out in all cases of double vision. Thank you.
Thank you, Dr.